All right, the next bill on the agenda is House File 1752 from our own Chair Liebling. And House File 1752 will be laid over for possible inclusion in the omnibus bill.
Yes, thank you, Mr. Chair. That is my motion, and I would like to move the DE1 amendment to put the bill in the shape in which I would like to have it discussed today.
The amendment is moved and the bill is in the order you wish it to be in.
So we need to vote on that motion, Mr. Chair, so.
Oh, okay. So motion to approve the amendment as moved.
Okay, all in favor?
All in favor? Aye. Opposed? All right. So moved. Amendment is adopted.
Thank you, Mr. Chair.
Proceed with your bill. Yes,
Thank
please.
you. And so, members, this is a bill that, this idea has been before the legislature before in the last cycle. I had a bill like this. What this does is carve out the pharmacy program from the managed care organizations and run it all under fee-for-service. We've heard a number of bills this session already about the managed care organizations. Representative Freiberg has a bill, or sorry, Representative Fisher has a bill to get them out of the business altogether. But this just carves out the pharmacy. So this is an alternate proposal. And so this was actually, in prior years, it was part of the governor's proposal. This year it is not, but I'm bringing it back, and because I think it is extremely important legislation. I'm not going to talk much more. I have with me Luke Slindy, who is going to present the bill to you and explain to you the importance of it, and it is very compelling, and I hope you will, it is to me, and I hope you will all find it so as well.
Thank you, Representative Liebling. And Mr. Slindy, if you could introduce yourself for the committee and proceed.
Thank you, Chair. Good morning, Madam Chair. I am Luke Slindy, a second-generation Minnesota pharmacist, and I'm here today to discuss rural community pharmacies, the medical assistance drug program that over 1.4 million Minnesotans use for their medication benefit, and the state's use of for-profit pharmacy benefit managers in that program. I grew up in Harmony, a small town south of Rochester. Many of you may be familiar with Harmony's representative, Greg Davids. For reference, I know him well and attended school with his children. For many years, my family owned and operated Slindy Pharmacy. Like many Minnesota small towns, it was the only pharmacy in town. However, in 2007, when I was still in pharmacy school at the U, my family decided to sell the business to another small local chain. The primary reason? Abusive and anti-competitive business practices from very powerful for-profit pharmacy benefit managers, or PBMs, and unsustainably low payment rates. Fast forward to 2022, increasingly worse conditions caused the new owners of the pharmacy in Harmony to close the business altogether, leaving Harmony without a pharmacy for the first time in over 100 years. Unfortunately, Harmony's circumstance is not unique. Here is a list of Minnesota cities that had a pharmacy in town in 2006 but currently have no pharmacies. You may recognize a town on this list in or near your own district. The loss of a rural pharmacy creates significant barriers to healthcare access and the loss of economic vitality due to the absence of an anchor small-town business. Now let's talk about Medicaid in Minnesota. As of January 2023, approximately 85% or 1.2 million Medicaid beneficiaries receive their pharmacy benefit via a for-profit PBM, subcontracted from a managed care organization. For these 1.2 million patients, a pharmacy is paid by and is forced to interact with one of the for-profit PBMs on this list. Fortunately, there is good news. Minnesota has an already existing Medicaid fee-for-service program that currently covers the remaining 15% of beneficiaries, pays pharmacies directly from the state, and treats pharmacies much more reasonably. This chart highlights 4 key ways the fee-for-service program is better for Minnesota pharmacies compared to for-profit PBMs. One main benefit is transparency. The network contract terms and the payment rates to pharmacies under the fee-for-service program are public information, in contrast to for-profit PBMs, whose network contract rates and opaque maximum allowable cost MAC rates are considered trade secrets and proprietary. Unfortunately, I have learned that in pharmacy, proprietary means we are going to keep this information secret in order to take advantage of everyone who is not us. To reinforce this point, prior to submitting a claim to a for-profit PBM, a pharmacy has no idea what the payment rate ultimately will be. Another benefit of the fee-for-service program is the source of payment rates. To determine dispensing payment fees, the fee-for-service program collects cost accounting data from pharmacies themselves to help determine reasonable rates, allowing pharmacies to participate in the payment rate setting process. This cost data separately quantifies the acquisition cost of the drugs or the price a pharmacy pays to stock each drug on its shelves, as well as the actual costs of dispensing, including staff wages, rent for the building, and other operating costs. Alternatively, the processes that for-profit PBMs use to set payment rates is, again, proprietary and a big mystery. The final benefit of the fee-for-service program I will discuss is a lack of patient steering. Patients under the fee-for-service program may fill their prescriptions at any network pharmacy, while for-profit PBMs often attempt to force a patient to use a mail-order pharmacy or other pharmacy owned by the PBM, creating a lack of patient choice. And the entire last bill was an example of this. The coerced use of PBM-owned mail-order pharmacies is particularly detrimental to rural pharmacies. In my opinion, the evidence is clear. The existing fee-for-service program is much better for patients, pharmacies, and the state. And many other states agree with me. Here is a list of states that have already removed for-profit PBMs from their Medicaid pharmacy benefit while still retaining managed care organizations for medical coverage and other non-pharmacy benefits. As you can see from this mix of states, this proposal is not a traditional partisan issue. I thank Chair Liebling for once again authoring this important legislation, and I humbly request you support HF1752 to remove unnecessary and harmful PBM payers from medical assistance, transfer pharmacy coverage for all beneficiaries to the existing fee-for-service program, provide better access to needed patient medications, and help preserve the state's rural community pharmacies. As a final note to 340B covered entities and the amendment being offered today to address some of the covered entity revenue concerns, we encourage stakeholders to work with Representative Liebling to come to an agreement on how to offset potential 340B revenue losses. Other states that have already completed this process have been able to redress this issue and fully implement a fee-for-service model for their state Medicaid pharmacy benefit. Thank you, committee members, for your time, and I'm happy to answer any questions.
Thank you, Mr. Slindy, for your testimony. We have another testifier, Mr. John Hessian.
And Mr. Chair, before we go to the other testifiers, could I finish just presenting the bill?
Absolutely,
Thank you, Mr.
Representative
Chair.
Liebling.
So
Proceed.
I hope that from that members understand that besides so many other reasons why, as legislators, running the pharmacy program through the managed care organizations is bad for us and probably far more costly for the state than it needs to be, we're also killing our small pharmacies with this program. And I think that Mr. Slindy's testimony to that effect is very compelling. But I also do want to tell folks that the DE1 also has language that attempts to deal with the 340B program, because as you all who were here before may remember, the pushback we got on the bill is because of the operation of the 340B program, which is a federal program which has drug companies giving deep discounts to managed care, or let's see if I can explain this. They're giving deep discounts on their prices. This is really, it's funny because hardly anybody actually does explain it very well.
Yeah.
But anyway, let me put it this way. There is a hidden subsidy that is flowing through the managed care programs to a lot of organizations that we all know and value, hospitals, clinics, et cetera. And so when you start to say we want to get the MCOs out of this business, some other organizations say, hey, wait a minute, you can't take our money away. Well, this is a hidden subsidy. We as legislators are funding this without even knowing how much it is or where it is going. So one of the things that this bill attempts to do, and I will continue to work on, is to try to get our arms around where that money is going, how much it is, and attempt to hold harmless these organizations that we are not intending to hurt with this bill. But we will be in a much better position if we are able to accomplish this. The other thing that I've done in the amendment is to require, because there's an effective date that's out pretty far on this, just for DHS to be able to accomplish this would be January of '26. The bill also would require that the MCOs in the meantime reimburse the pharmacist for the cost of filling a prescription at the fee-for-service rate. So a pharmacist the other day showed me his receipts, I guess you'd call it, where we, the state, reimburse $10.77, I believe it is, right now, for the cost, and this is cost-based, based on a study, what it costs a pharmacist to fill the prescription. The MCOs are paying pennies for a prescription, so like 10 cents or 15 cents, when their cost of filling the prescription is at least the $10.77. That's the average cost. So you can understand how hard it is to stay in business when you're getting that kind of reimbursement, and when some of the time you're actually paying more to acquire the drug than you are being reimbursed for the drug. So with that, we'll take the other testifiers, Mr. Chair.
Thank you, Representative Liebling. And next up is Mr. John Hessian. If you would state your name for the committee and then proceed, please.
Thank you for letting me give some comments here today. My name is John Hessian. I am a pharmacist of 34 years and the current owner of St. Paul Corner Drug, located in the McAllister Groveland neighborhood of St. Paul, where I've practiced since 1989. Like most other independent pharmacies, we offer a high-touch, patient-centric level of care with the goal of meeting our patients' needs wherever they are along their health journey. I am speaking today in support of House File 1752 on behalf of all the other independent pharmacies and pharmacists located throughout Minnesota. I know that every one of them wishes they could be here to voice their concerns regarding the current state of community pharmacy here and across the United States. I hope to impress upon you the gravity of the matter at hand and what can be done now to avert an already developing health crisis in our state. Over the past 6 months, my pharmacy filled approximately 4,000 prescriptions under the Prepaid Medical Assistance Program, also referred to as PMAP. That is roughly 10% of our volume. Of those 4,000 prescriptions, 650 of them had a gross revenue of less than $4. 300 of them came in at less than $2, with the lowest reimbursement being 3 cents for a prescription we dispensed 3 times over that 6-month period. Of the 4,000 prescriptions filled, 1,600 or 40% of the claims had a gross revenue below the current statutory dispensing fee of $10.77. This fee amount is determined by surveying pharmacies across Minnesota to establish what it actually costs to dispense a prescription. For those 1,600 prescriptions, we essentially gave the product away free and did not even recover our cost of doing so. 400 of these 4,000 prescriptions were brand drugs, ranging in cost from $200 to $2,400. The total drug inventory for these 400 drugs was about $200,000. Nearly 100% of these brand drug claims were reimbursed at or below actual acquisition cost of the product, with no account for any overhead costs such as labor, rent, insurance, licensure, supplies, etc. To my fellow business owners in the room, when was the last time you purchased $200,000 worth of goods and sold it all below cost? This is absolutely 100% unacceptable, unsustainable, and abusive. If something doesn't change now, more pharmacies will close, including mine. Where will these patients go for service? The answer to that question is not down the street to the chain pharmacy. During September and October of 2022, the closest pharmacy to us had significant decline in service level due to staffing and other issues. We were taking on anywhere from 10 to 15 new patient transfers, not scripts, patient transfers, all of their stuff, 10 or 15 a day. By November 1st, we could no longer safely continue to accept additional patients and made the decision to stop taking new prescription patients effective immediately. That policy is still in effect today because we are still beyond capacity, with staff coming in early and staying late just to keep up with our workload. In recent weeks, the last pharmacy in North Minneapolis closed its doors, along with the area's last grocery store. CVS and Walmart have both announced that they are cutting their service hours from 9 p.m. to 7 p.m. at nearly 2/3 of their pharmacy locations nationwide. Communities like North Minneapolis and rural areas are home to some of the most vulnerable individuals that rely on the Medicaid program for their health needs. Losing access to pharmacy and food supply creates a whole new kind of social desert, and along with it, set of challenges for these folks. Many may not have time during the normal business hours or reliable transportation to be able to travel to the nearest pharmacy, which is now almost 4 miles away. In short, a health crisis. If nothing changes, there may never be another pharmacy in North Minneapolis. However, if this bill becomes law, there could be a pharmacy in North Minneapolis by the end of 2023. This proposed legislation is that pivotal to the matter at hand. Over the past 2 decades, we've been told there's nothing the legislature can do regarding reimbursement for pharmacy claims due to Medicare and commercial plan exemptions. That is not the case with Medicaid. The state is already adequately paying for this service. But by the time the money gets to the actual provider, me, there is nothing left. The middleman is taking all the resources and completely decimating the pharmacy provider network of Minnesota. This must stop, and it can. I implore you to make certain that this bill makes its way through the legislative process this session before it is too late, or I fear many areas of Minnesota, both rural and metropolitan, will be without pharmacy services for a very long time. I thank you for your time, and I can answer any questions anyone has.
Thank you, Mr. Hessian, for the testimony. Anyone else in the public that would like to testify on this bill? Seeing none, we'll go to member questions and discussion, please. Representative Schumacher.
Thank you, Mr. Chair, and really more of a process question here. Again, I understand there wouldn't be a fiscal note yet on this, that's going to be still in the process, but just comparing this to the 2019 bill and the fiscal note there, of course, some of the dollars are going to change, but has the policy changed significantly that you're expecting it? Are the assumptions going to be similar within that, or will those be different as well? Particularly the part about DHS needing to pay back the MCOs for the withholdings that they currently have on that. Thank you.
Representative Liebling.
Yeah, thank you, Representative Schumacher. Well, there is a lot different here. The 340B program is significantly different. And I have no idea what that would cost, frankly. That's kind of part of the problem, right? We have no idea. And also I put in here the requirement to pay, for the MCOs to pay that 1077 between now and when this bill would go into effect. Otherwise, we're going to lose pharmacies. When I heard these stories, I'm just, you know, I mean, I brought this bill last time, but I really didn't realize the impact that it has. So it is different, and I eagerly await the fiscal note, because I really think this is a crisis situation for pharmacies across the state.
Thank you, Representative Liebling. Follow-up? No follow-up. Representative Nadeau.
Thank you, Mr. Chair. I wasn't here in 2019, so I don't really know, but thank you, Representative Liebling, for bringing this up. It won't be a surprise to you that I'm always supportive of more options rather than less, and I'm not sure that the PMAP example that was given is probably the best. You know, this is our lowest income people. You know, there's a lot of services that people on PMAP get. I mean, everything from reduced classes in the community to car seats to, I mean, it's not just reimbursement for prescriptions. So I don't know if that's the greatest example. Do we need to do something? Absolutely. I totally agree. But I'm not sure that this is the right thing. The question that if we're going to move and DHS is going to become the PBM, for example, my understanding is that DHS is prohibited. I mean, are they licensed to be a PBM? My understanding is that statute right now prohibits the Department of Human Services to be a PBM. That's my first question. And the second question, will they have a preferred drug list? And if they do, who will, I mean, right now DHS oversees those preferred drug lists for MCOs. Who will be that overarching entity at that point to oversee DHS? I guess those are two questions.
Representative Liebling.
Thank you, Representative Nadeau. Two things. One is we're not here to re-debate the Fisher bill today. This is not about getting rid of the MCOs altogether. It's about carving out the pharmacy program. That's the bill we have before us today. So that's what we're here to discuss. So, and the other thing is that they already run a program. We've heard about it in this committee. We'd heard about the pharmacy, pharmacy committee we talked about, and we had Chad Hope, he's here. I mean, I don't want to, again, we have a lot of other business to do today. I don't want to relitigate what we already did here in the committee, but they are already doing it. They have the fee-for-service program running. It works very well, as you heard here in the testimony. And they don't need to be a PBM. I'm not really sure where you get the idea that they would become a PBM. They're already running the Medicaid pharmacy fee-for-service on the fee-for-service side. So I think there would be other opportunities to talk to DHS about that if you would like, but we're not reinventing the wheel here. We're just putting the rest of the population that is covered under MA into the existing program.
Thank you. Representative Backer.
Yeah, thank you, Mr. Chair. One of the pharmacies on the screen was one in my community, and another one was in the district. And my daughter and I have talked about this. She's a pharmacist in Representative Keel's area. So I really appreciate what you're trying to do. I really do. My concern, though, is will the state have a greater success than PBMs with negotiating the prices? We can see the problem, but as we have talked about, this is new territory. My concern is that the best option? Is an agency better than the PBMs at negotiating the prices and so forth? So that would be my question. What would be your take there, Madam Chair?
Representative Liebing.
Thank you, Mr. Chair, and Representative Backer. So federal law governs this, and they get discounts under federal law. And I mean, I could get Mr. Hope. I think if he's still in the room, or here he comes. I mean, I don't really want to get into all of it right now, but yes, I mean, they have mechanisms for this, and they're doing it for 20% of our population now. So I don't know if you have anything to add to that, Mr. Hope, if you want to state your name for the record.
Welcome to the committee, Mr. Hope. Please state your name and proceed.
My name is Chad Hope with the Department of Human Services. I oversee the pharmacy program. Representative Liebling is correct. We have been performing these functions since 1991 for the fee-for-service program. As far as the prices that are paid and negotiated, we are actually in a almost a better spot than the PBMs because we have access to the federal Medicaid drug rebate data that the PBMs do not have access to. That's a mandatory program out of the federal government that's a condition of accepting federal funds for the program. So without that knowledge, the PBMs don't actually know what the lowest cost products are. They only know what the lowest retail cost products are.
Yeah.
Thank you. Mr. Backer.
Yeah, thank you. And I appreciate that. And that's why the bill's before us here to get into the details. We have had a track record that agencies have not performed well in certain arenas. I would want this to be successful because the course that we're on right now with the pharmacies, I already lost 2 years ago the pharmacies, not I, but our community did in Browns Valley and then in Ashby nearby. So I'm just concerned. It looks good on paper. I just think we need to dive into it more, but I do appreciate what you're doing, Madam Chair. Thank you.
Representative New Brindley.
Thank you, Mr. Chair. And Mr. Hope, if you would stay, I appreciate that you were here. I was hoping you would be. My question is for you, particularly with these changes to 340B. What PBM does DHS use now, and what do you do with the rebates now? Do they go directly to the consumer or the pharmacy, or what do you do with those rebates now? How are those used?
Mr. Hope.
Mr. Chair, Representative, there is not a PBM for the fee-for-service program. DHS directly administers the program ourselves. And the rebates, we are directly invoicing the manufacturers, collecting the funds. They get deposited in the state accounts and shared with the federal government based on the split for the programs. And then those funds are returned to the general fund as far as financing the Medicaid program. So none of that stays with DHS. It goes back into the funding of the program itself.
Thank you. Representative New Brindley, follow up?
Thank you, Mr. Chair. So right now, then, those funds are used to offset the cost of the program overall.
Mr. Hope.
Mr. Chair, Representative, that is correct.
Okay, Mr. Chair.
Yes, proceed.
Thank you, Mr. Chair. I thank you for that response. And I do have some concern about this because of that, because I think that generally speaking, that's how the rebates are used across the board. And so there are a lot of unknowns with, as Chair Liebling indicated herself, that we don't know these things, but what we do know is that right now those rebates are being used to offset total costs. And so I have some concern about what we're doing with that without that complete set of knowledge. Thank you, Mr. Chair.
Thank you. Representative Fisher.
Thank you, Mr. Chair. Thank you, Representative Liebling, for bringing this forward. I think this is a very critical part that we need, that we're getting a handle on. And I think what we're looking at is that while we're hearing that supposedly the current program is saving costs, what we're finding out is the expenses, we're cutting back on services that are available for the people of our state of Minnesota. And that's what motivated me with the bill I had out there. And we're seeing it's not just in clinics, we're seeing it all over the place in pharmacies. And what it does is the holes that we create don't get filled out there. And it means that we have less and less available for services for our people throughout the state of Minnesota, primarily hitting parts that are rural and parts that are communities of color. And I think it's very important for us to take a look at. I think that there will be savings in here that will actually defray the cost of the programs and make sure that we continue to keep these providers throughout the state of Minnesota alive. And I think that's the important part that we have to focus on, is what are the services for the state. So thank you, Representative Liebling.
Any comment, Representative Liebling?
No, I guess we had another testifier that needs to be able to
Yes.
testify, and so I guess I would just ask if we could.
We can go to the
Move to him.
other public testifier, and then we will have Representative Keel and Representative Elkins, and then we will lay it over.
Thank you.
Please state your name for the committee, please, and proceed.
Thank you, Mr. Chair. My name is Danny Eckert, and I serve as the Director of State Government Relations for the Minnesota Hospital Association. House File 1752 proposes to transfer Minnesota's managed care outpatient Medicaid pharmacy benefit to a fee-for-service model. While it is not explicitly stated in the bill and as mentioned by the bill author, an unintended consequence caused by the complete transfer of the benefit to fee-for-service triggers a federal rule that will eliminate an estimated $125 million annually in savings for eligible safety net hospitals that participate in the 340B program. This estimate does not include impacts to other safety net providers participating in the program. For your reference, we've submitted an issue letter and issue brief for more details on this. To be brief, so we appreciate the chair's new approach in the DE amendment and the recognition of the unintended consequences to 340B and Minnesota's safety net providers. At this time, we are still assessing the new language and its changes to how the bill as amended impacts the federal 340B program in Minnesota. So we look forward to working with the chair, with this committee and the legislature as this bill continues through session. And I stand for any questions and I'm happy to follow up with anyone to talk about 340B.
Thank you for your testimony. I appreciate that. Representative Keel.
I'll pass.
Representative Keel passes. We have Representative Elkins.
I had a quick question for Mr. Hope, if he's still here.
Yes, he is on his way down.
Oh, I can state the question while he's running down
And
here.
I believe he is still on the record for, so you may just proceed, Mr. Hope.
Yeah, I was curious, do you know, Mr. Hope, how the 340B prices compare to the Medicare prices that you have through the federal government?
Mr. Chair, Representative, I'm assuming you're asking the difference between 340B price and the Medicaid rebate net costs?
Yes.
Mr. Hope.
Mr. Chair, Representative, so the prices are similar. 340B can be lower than the net cost after the Medicaid rebate. We unfortunately don't have access to the direct 340B prices. HRSA doesn't release those. We are able to calculate what's called the 340B ceiling price estimate using two confidential numbers that we can't disclose to anyone because of federal law. But in a nutshell, it tends to be slightly lower on the 340B side than our net cost, but whether it's meaningfully so, it's hard to say.
Okay, thank you.
Any follow-up? No follow-up? You're complete? Very good. All right. We can have final words.
All right, just thank you, Mr. Chair, and I'd like to just lay the bill over.
Thank you. The bill as amended is laid over for possible inclusion in the omnibus.
Thank you.